wanting to join us, and we'll start off. So it's, I think we're going to start off. So hi, I'm Katrina, and I'm the Events and Finance Coordinator for BUSOG. Thank you so much, everyone, for joining us on this Saturday afternoon. If you're joining us for the first time, you're welcome. If you're coming from our previous events in the BUSOG webinar series, thank you again for continuing to show interest. So today we'll be looking at preeclampsia, and we have two amazing speakers, Dr. Kellyanne Eastwood, who is a consultant obstetrician and gynecologist, and Alice Clements from Action on Preeclampsia Network. We'll be the structure for today will be Dr. Kellyanne will start off and we'll do a Q&A session, and then we'll hear from Alice in the second part of the webinar, and again do a Q&A session using Slido. So just some housekeeping event. We would encourage you to stay until the end of the event where we will share a link to access the feedback form, and you will only be able to get the certificate if you fill in the feedback form. So if you've got any kind of issues with that, we will be staying, after the event if you need that sorted out. And one final mention is that we're very lucky to be sponsored by Teach Me Obs and Gynae. So they've got some wonderful resources in Obs and Gynae. I would recommend that you visit their website. Without further ado, I'm going to hand it over to you, Kellyanne, and we'll start off the event.
Brilliant. I'll just share my screen.
Yeah.
Can everybody see that?
Yeah, we can see that, Kellyanne.
Brilliant. All right, I'll make a start then. So thank you very much for inviting me to speak today. Preeclampsia is a topic which is very close to my heart, and I spent 3 years of my PhD looking at preeclampsia. So today I'm going to talk about new approaches to a very old problem. So if some of you are Downton Abbey fans, as I am, you might recognise this horrendous scene where poor Lady Sybil has just delivered her daughter and sadly died as a result of preeclampsia. And you can see on the right-hand side of the screen the poor family GP turning away, as there was really nothing he could do. In 1920, mortality from eclampsia was as high as 30%, compared to a mortality rate of 8% had Lady Sybil had a caesarean section. And preeclampsia essentially has been around for a long time. It was first discovered in ancient Greece by Hippocrates, who made a link to a pregnancy-specific condition complicated by headaches, heaviness, and convulsions. And at that time, a bit like the 1920s, there wasn't much clinicians could do. So they altered diets, they purged women, and they bloodlet because they thought it was due to an imbalance of the humours. During the Middle Ages, medical and scientific progress largely came to a standstill due to the influence of Christianity. Medical schools were closed and human dissection was forbidden. But in 1600, Pope Clement VIII granted permission to teach anatomy by human dissection. And by the 17th and 18th century, the French were making some strides in the area of eclampsia. So they recognized that it was a syndrome associated with the presence of edema, that there was proteinuria involved as well. But actually it wasn't until 1896 that we had the ability to measure blood pressure. And then it became recognised that preeclampsia was indeed a hypertensive disorder. In 1924, a physician called Edmund Lazard in Los Angeles described the use of magnesium sulfate to control eclamptic seizures. And actually, he later admitted that it was his poor old intern that first actually suggested use of mag-sulf. So broadly speaking, all of you who either choose to pursue a career in obs and gynae will come across hypertension in pregnancy. It affects between 6 and 10% of pregnancies. And overall, there's a decrease in blood pressure in the first and second trimester. And it's important to know what happens actually physiologically, because this can help you to better understand, diagnose and manage preeclampsia. In the third trimester, blood pressure importantly increases to the pre-pregnant level, and postpartum, the blood pressure falls immediately after delivery. So often women with preeclampsia will be taken off their tablets for 24 to 48 hours, but you start to see that peak in blood pressure between day 3 and day 6. So preeclampsia is a global problem. It affects around 4% of pregnancies worldwide. However, its incidence in high-risk patients can be as high as 20%. And sadly, in the UK, 5 women died as a direct result of preeclampsia or eclampsia in the last triennium. So let's think about why we get preeclampsia. Well, there are many theories as to the etiology of preeclampsia. In women who develop it, placentation appears to be abnormal, with impaired invasion of the uterine deciduum and myometrium. And this leads to inadequate remodeling of the maternal vasculature, namely the uterine arteries. And overall, this results in impaired uteroplacental perfusion. But this isn't the whole story. There's also this influence of angiogenic imbalance. So angiogenic markers are biomarkers which are basically flung out by the placenta during pregnancy. And in the preeclamptic situation, there's typically an imbalance of these. So we see high sFlt1 and low PLGF. PLGF is placental-like growth factor. And these processes are also influenced by a number of other things, including maternal risk factors such as diabetes, maternal BMI, hypertension, pre-existing hypertension, oxidative stress, acute atherosclerosis, and also immunology. So sometimes the trophoblastic cells have problems actually talking to each other. They don't signal that well, and that means that they're not behaving in the way they should. So here's what happens in the normal placenta at the top of the screen. You can see the normal adaptive response to pregnancy is represented with trophoblast invasion of the myometrial wall of the uterus and remodeling of the spiral arteries. And as I said before, this leads to increased blood flow through the uteroplacental unit. So you want to get as much blood flowing through that placenta to the fetus on the other side. In contrast, the slide below represents the preeclamptic placenta, where there is impaired invasion of the myometrium, impaired remodeling of the maternal vasculature, and this leads to really tight constricted blood vessels under which blood is under higher pressure. So it's interesting to think about the diagnosis of preeclampsia, because actually it has changed somewhat. There we go. Sorry, I think I was muted there. Okay. So it's defined essentially as hypertension developing after 20 weeks gestation and the coexistence of one or more of the following new onset conditions. These include development of proteinuria, other maternal organ dysfunction such as renal insufficiency or liver involvement, and thirdly, uteroplacental dysfunction. And this is most often represented as fetal growth restriction. And this is very important because before fetal growth restriction didn't play a part in our diagnosis of preeclampsia. So even when I started obs and gynae training, if I saw a woman with high blood pressure and a small fetus, I wasn't automatically labeling her as having had preeclampsia. Whereas now we're probably perhaps picking up preeclampsia more readily in pregnancy. So it's interesting to think about from an obstetric point of view. As you may well know, sadly, preeclampsia is associated with a number of maternal, fetal and neonatal complications, including HELLP syndrome. For those of you who don't know what this is hemolysis, elevated liver enzymes and low platelets. You can also get DIC, multi-organ failure, and sometimes mums need admitted to ICU, may suffer a stroke or even death. And it's also important to think about what happens to these women after pregnancy, because in fact, what happens during pregnancy really influences the life course of a woman's physiology. So she's more likely to develop hypertension later on in life and also metabolic syndrome. Fatal complications sadly include miscarriage and stillbirth, i.e. GR I've mentioned, and not forgetting that we still haven't found a cure for preeclampsia. The only known cure is delivery of the placenta. So often we're having to deliver these little fetuses prematurely, and they may have complications of this, including HIE. So this brings me on to a patient of mine who actually I started working as a consultant in Bristol fairly recently. I was working in Belfast before that. And I think this patient's going to stick in my mind for a while. So it's really back to basics, and this is probably teaching you how to suck eggs, but it's history, examination, and investigations. So I'm a maternal and fetal medicine specialist. I love scanning people. If you're with me on labour ward, you'll often see me trundling along with an ultrasound machine. But actually, it's really important to get the basics right before jumping on the fancy kit. And part of this is actually knowing your patients. So thinking about the risk factors for preeclampsia is really important whenever you're trying to take a good history. What age are they? Are they extremes of maternal age very young, or are they a bit older? Are they overweight or obese? Have they had preeclampsia before? Is there a multiple pregnancy, a fetal abnormality? What medications are they on? And we know that women who are from socially deprived backgrounds or lower middle income countries are more likely to have preeclampsia. And smoking could well be a surrogate marker of a lower socioeconomic background. So it's important just to consider all these things. So if I draw your attention to the right-hand side of the screen, some of you may have already clocked there the placenta, and you can see it's quite a big placenta. There are there's an image here of two fetal abdomens, and then you can see this lovely lambda sign. This tells us that this is a diamniotic dichorionic diamniotic twin pregnancy. So this lady was a PAR3 at 27 plus 4 weeks gestation. As I said, she was one of the first patients I saw on my fetal medicine list. So I was really sitting there with my fetal medicine hat on thinking, right, I need to scan these twins, I need to check the growth. But actually then when I started talking to the patient, it appeared that a lot more was going on. Her last child was born 10 years ago. Her booking BMI was 30. She was a smoker. She had a new partner. And unfortunately, she reported a 2-day history of frontal headache and ankle swelling, and also was complaining of reduced fetal movements of one of the twins. Sadly, she comes from quite a deprived area outside of Bristol, so she couldn't afford to take a bus up to Bristol any sooner. So she thought she'd just wait for a fetal medicine appointment to be seen. When I examined her, she had bilateral peripheral edema, a blood pressure of 165 over 105, 3 pluses of protein in her urine, and very brisk reflexes. Of course, I did get my fancy kit out and have a look at the fetuses, and this showed normal fetal growth and Dopplers. Now, I just wanted to post a little question. If any of you are celebrity fans, you might recognize who these ankles belong to, a famous celebrity who did have preeclampsia in her pregnancy. So you can post answers in the chat after the presentation. So what did I do next? Well, firstly, I admitted her. Hopefully all of you would too with that impressive blood pressure. I sent off maternal bloods, sent her urine for protein creatinine ratio, and started her on antihypertensive medication. So typically we like to use labetalol in pregnancy if women don't have any contraindications to this, such as asthma. So I give her 200 milligrams of labetalol twice a day. So let's set Miss CS to the side and then think about preeclampsia research and what's been happening in that field over the last number of years. So the whole idea of antenatal care was first introduced by the Ministry of Health in 1930. So almost 100 years now that we've had sort of defined antenatal care, if you like, in the UK. Of course, in 1930, we didn't have nice ultrasound scanners to use, so women really probably didn't realise that they were pregnant until they'd missed a couple of periods. So they turned up usually around 16 weeks, and then were seen more frequently as their pregnancy went on. So this is often described as a pyramid model of antenatal care. And actually, most of the research in the area of preeclampsia has been trying to challenge this pre-existing pathway of care. And one of the ideas has been around developing integrated screening tools which can be used early in pregnancy, around 12 weeks gestation, to try and identify women at greatest risk of preeclampsia. So it's about turning this antenatal pathway of care on its head. Screening, however, in most hospitals throughout the UK is based on guidance from NICE, but we know that combination of several first trimester screening methods increases the predictive value of this screening model. And many research groups have looked at the use of uterine artery Doppler ultrasound, measurements of maternal mean arterial blood pressure, and inclusion of background maternal characteristics, which I've mentioned, sort of high-risk characteristics such as ethnic race, BMI, gestational age, for example. And also, more recently, a number of people have begun to look at placental volume measurements. And this brings me on to, I've taken the liberty of talking just very briefly about some of the research I undertook during my PhD. So I ran a study called PREDICT, which was a prospective longitudinal observational study involving 4 groups of high-risk women, those with diabetes, those who were entering pregnancy with obesity, those with a previous history of hypertension, and those with thrombophilia or autoimmune disease. And the idea was to try and assess the ability of first and second trimester placental vascularization indices to try and predict preeclampsia in these high-risk women. So how did I do this? Well, first of all, I made use of 3D ultrasound. And the reason that this is quite novel is because it's a non-invasive way of trying to identify or assess placental vascularization and flow through the placenta. So there's a program called VOCAL, which is a whole volume means of assessing the placenta, where essentially we can virtually reconstruct a vascular tree within a volume of interest, in this case, the placenta. So how does this work? Well, it uses power Doppler to measure voxels within an area of interest. And a voxel essentially is a value within a regular grid in a 3D space. I measured 3 things. Firstly, vascularization index, which is the number of vessels within the placenta. Then I looked at flow index, which is the intensity of flow within that vessel. And then VFI, which is vascularization flow index, is a ratio of these 2 parameters. And this is how I did it. So this is an ultrasound image from one of my patients taken at about 12 weeks of gestation. Here you can see the posterior placenta, and the power Doppler is just highlighting the blood flow in the placental bed and a little bit in the placenta in that image. The first thing to do is identify the placental mass using 2D grayscale imaging. And then once you've done that, essentially you position the placental mass within an image acquisition box. The ultrasound scanners are really clever, so you acquire a 3D volume and analyze this offline by measuring around the placenta. So we're able to rotate the placenta through 30-degree rotations to ensure that we're accurately assessing the whole placenta. And then after doing this, we can generate a placental volume histogram to obtain the placental vascularization indices that I talked about before. And this work was published in Placenta in 2018. And essentially, we showed that lower first trimester placental vascularization indices were seen in women with preeclampsia. And even when we controlled for other things, so all of these other covariates or risk factors, such as maternal age, obesity, different, and the different medical conditions that they had, it still showed that over and above baseline characteristics, these indices independently predicted the risk of preeclampsia in the first trimester. So just to say, this work hasn't yet translated from the research world, if you like, into clinical practice, but often you find that there's quite a lag time between the work that we do in the lab or using ultrasound to actually getting that into guidelines, into NICE or RCOG guidelines for regular practice. But let's move on to the present. So this is hot off the press, can I just say, and I've taken the liberty of stealing a few Zoom slides from a webinar that I was actually at last weekend. So some of you may have heard of Professor Kypros-Nicolaides. This is him here down on the right-hand side of the screen. So he's sort of known as the godfather of fetal medicine in the UK. He set up this organisation called the Fetal Medicine Foundation, which has done a huge amount of work in preeclampsia research, particularly in the area of prediction of preeclampsia. And one of the first things that they did was actually to look at NICE guidance and see how well was that picking up women at the beginning of their pregnancy, how well was that performing to predict their risk of preeclampsia. And then what they did was try and develop some alternative screening methods and see how well that performed in comparison to the NICE model. So here, for example, you can see that that around 50% of women were predicted just on maternal history alone. And this was prediction for preterm preeclampsia. But when you added in other things such as mean arterial blood pressure, uterine pulsatility index, and measurement of placental-like growth factor in the first trimester, suddenly the predictive model went up to 90%. Now you can see across both models prediction for moderate or late onset preeclampsia is poorer. So for women who develop preeclampsia, late onset preeclampsia after 37 weeks, even with Nicolaides adding in these additional factors, he was still only able to predict 44% of pregnancies affected or potentially affected by preeclampsia. And this is probably because these markers that he's using are more focused on the types of preeclampsia which are early onset affected and linked to abnormal placentation rather than maternal risk factors. However, there is a new kid on the block, and this is why I wanted to show you this, because this is literally just hot off the press. So in the 1990s, they actually discovered that when you ultrasounded the ophthalmic artery in pregnancies with preeclampsia, they noticed that there was a decrease in pulsatility index and an increase in velocities. And actually, if you remember back to your physiology or your anatomy, the ophthalmic artery is the first branch of the internal carotid artery. And very cleverly, it tells us what's happening in the microvasculature. So you're going to see changes in the eye quicker than you would see changes in the uterine artery Doppler. And by ultrasounding essentially the eyeball, you can look at the pressures and flow through the ophthalmic artery. So this is what the Nicolaides group have been doing. And here you can see that on when they looked at prediction of preeclampsia within 3 weeks, they were able to kind of improve performance of the algorithm by an additional 38%. So in the blue box, they just applied the traditional sort of history taking from NICE. What they haven't done yet is add in ophthalmic artery Doppler to those other parameters that I talked about, such as uterines and PLGF. So they're still recruiting women to try and see what the effect of it is. But I can see this coming into clinical practice because it's going to be very cheap and very easy to perform. And according to them, the difference in operators, so they looked at, they checked obviously to make sure that it's reproducible, and apparently it is. So that's quite exciting. And back to my patient. So what happened to her? So on the 2nd of November, when she was admitted, we did her bloods, as I've said. So her hemoglobin was 110, her platelets were 83, so a little bit on the low side. However, her LFTs were normal and her creatinine was stable. Her urate was a little bit increased. So as a general rule of thumb, at 30 weeks, the urate should be around 300, at term 400. And remember, when I saw her first, she was, I think, 27 weeks and 4 days. But what you can see is that she had this hugely elevated PCR. So that's the protein creatinine ratio. A value of over 30 is considered abnormal. So hers, she had very heavy proteinuria, which we knew already because of the 3 pluses of protein went just on dipstick. But when we quantified it, we can say that this is quite worrying. I saw her the following day and her headache had settled. Her ankles, which had been up like balloons, really had gone down very well, and her blood pressure was well controlled. The following day, however, her platelets had fallen a little bit further to 78. And it was then I started to think, well, this lady has a diagnosis of preterm preeclampsia. How are we going to manage her, and how long is she going to get in her pregnancy? And these are quite difficult decisions to make, because ultimately, for the sake of the twins, you want to keep the pregnancy going as long as possible because of the risks of prematurity that I talked about. But then on the other hand, you're trying to balance the risks to mum. So you don't want her to have a stroke or an abruption or a fit. So it's difficult. These are definitely difficult and challenging decisions. But from experience, I know that often when you have very preterm preeclampsia, it's likely that you won't get that far in pregnancy. So it's really important to think early about how we can then optimize the care for the neonates. So I decided to give steroids, and steroids are given essentially to try and prevent pulmonary hyperplasia in the fetuses. I also had her reviewed by an anaesthetist because she had previous back surgery and bulging discs. And the neonatologist also came to have a chat with the parents to try and prepare them for delivery. By the 5th of November, her platelets had fallen a bit further to 78. And by the 8th, she started to contract and she had an abnormal CTG. So the team that was on over the weekend then made a decision to deliver her by emergency cesarean section. And they gave her magnesium sulfate. So you may remember earlier that I said it was used to reduce the risk of eclamptic seizures. A few secondary effects of the medication are, firstly, that it has a mild tocolytic effect, so it will help sort of settle the contractions. And also it's excellent for fetal neuroprotection. So little preterm babies are quite at risk of intracranial bleeds. And what magnesium sulfate does is stabilize the brain barrier. So she went on to have an emergency section of twins, Matteo and Tilly, who I can report are still in the neonatal unit but are doing well. And post-delivery, you can see that her platelets drifted further to 57, and she also suffered a bit of an acute kidney injury. But by day 13, her platelets had come up to the dizzy heights of 116, and pleased to say that she's away home now. So all ended well, but as I say, in delivery of preterm twins. So what were the learning points for me in this case? Well, firstly, and it seems obvious, but listen to the patient, but sometimes it's easy not to when you're busy. I was sitting in fetal medicine, and to be honest, I was thinking more about the twins than about the mother, but it's actually very important to consider the whole picture. As you can see, it took time to kind of see which way this was going to go. So you really need to watch the patient, her bloods and all the other clinical parameters very carefully, and think early about who else to involve. So it's a team effort, really. You need to think about the intensive care for the babies, those in delivery suite, and also have those conversations with the parents to try and help them prepare as much as possible for early delivery. So the last part of my presentation is just to talk about future risk. And this essentially is what I believe all good obstetricians should tell their patients. So if you've had preeclampsia before, it's very likely that you're going to get it again. And unfortunately, we still don't exactly understand why. We know that the mechanisms are pretty complex. Will probably involve some of the reasons why you got preeclampsia in the first place. And just to also allude to genetic predilections. So often you'll talk to patients and they'll tell you, oh, my mum had preeclampsia, my auntie had preeclampsia, two of my sisters have had preeclampsia, I had preeclampsia in my last pregnancy. And suddenly you start to piece together this really, really strong family history. And there's been an awful lot of work going on to try and identify genes which are associated with preeclampsia. Like most things, there's many genes have been identified, but none like, for example, BRCA, no mutations which have been strongly identified with genetic predilection of preeclampsia, but it's just something to bear in mind. And I always do ask patients about their family history. So what did I tell my patient? Well, I told her that she's at increased risk of having hypertension in her next pregnancy, so about a risk of 50%. If she gets preeclampsia overall, her risk is about 16% again. Because she had preeclampsia less than 34 4 weeks, there's about a 1 in 4 chance that she will get preterm preeclampsia or severe or preeclampsia again. And if she had been delivered at less than 28 weeks, then her risk of having preeclampsia would be over 50%. So these are, they're very, very significant figures and things, and I think it's really important that we do tell our patients about them because it may change what they do and how they plan their future pregnancies. They should also be aware of the increased rates of preterm delivery in the future, delivery of a small infant, a placental abruption, and with that comes perinatal mortality. And we also know that there is an economic burden of recurrent preeclampsia, including extended maternal inpatient postnatal stays and increased risk of admission to NICU for the babies. And the long-term significance, now I have to say, I don't think that, I think that obstetricians are not so good about focusing on the very long-term things. So often they're good at saying what the risks are for the next pregnancy, but not really thinking 10 or 20 years down the line. And that's because often we don't see these women again. But actually, I feel like it's my responsibility to chat to my patients about this as well. And because often it's the only time that you get a chance to tell them about future risks. So there's about a 4-fold increased risk that they will have hypertension at some point in the future. They're at double the risk of ischemic heart disease, stroke, and venous thromboembolism. And telling someone this is a bit like dropping a bombshell on them and walking away. So it's also important to say, well, what can you do about this? What risk factors can you modify to try and reduce these risks to yourself? So I do talk to them if they are overweight or obese about trying to get their BMI into a normal range, about eating better, looking after themselves, stopping smoking and doing a bit more physical activity. And it is important that they realise that their overall risk of mortality is increased 15 years, remains increased for 15 years after development of preeclampsia. So as I said at the beginning of my talk, what happens in your pregnancy is a bit like a stress test for the rest of your life. So it's really stressing your physiology and it really can change what happens down the line. So important to think about it. Now, the other thing we can counsel our patients about is use of aspirin. So I tell my patients that they should be on aspirin from at least 12 weeks gestation until delivery if they've had preeclampsia before. It's usually 75 milligrams once a day, but I'll come on to higher doses of aspirin as well. And just again to flag up the obesity problem that we have in the UK, we're, I'm not proud to say it, but we're 6th in the world, 26% adult obesity rate. The heaviest people, not surprisingly, are in the United States. And if you want to find really thin people, you're going to have to fly to Japan or Korea. But I don't see too many of these patients coming through my clinics. So last big piece of research that I just want to make you aware of is this paper from The Lancet. It was a pretty groundbreaking paper published a couple of years ago, and it looked at use of aspirin versus placebo in pregnancies that were known to be at high risk for preterm preeclampsia. That was defined as preeclampsia before 37 weeks. So it's very rare in obs-and-gynae to get an actual randomized control trial because women don't want to take risks with drugs that they don't have to take. You can understand that. So they had to screen nearly 27,000 women to be able to get 1,800 women randomized into these two groups. But what they found was that the risk reduction of having preeclampsia was very significant. So the incidence of preeclampsia in the aspirin group was only 1.6% as opposed to 4.3% in the placebo group. You can see the odds ratio there is 0.38. So that's a 62% risk reduction in preeclampsia. And this is using 150 milligrams of aspirin as opposed to the 75 milligrams that NICE recommend. And it's important when you are doing any big studies like this involving drugs that you look, did people take their tablets and how many people were taking their tablets? So about 80% of the participants did take their tablets and they took over 85% of the aspirin tablets. And again, importantly, was there any difference in adverse outcomes between the two groups? And there weren't. So essentially this work shows that it's safe to take the higher dose of aspirin in pregnancy if you're high risk of preterm preeclampsia. So last slide, take-home messages. Listen to your patients. These are lessons not just for obs and gynae, but for your medical training in general. Remember that preeclampsia is a multi-system disease. Remember to advise women of future risks and keep reading and thinking. Thank you.
Thank you so much, Kellyanne, for a truly wonderful and entertaining talk. If you would, we have a few questions here. So the top question is, how would you describe preeclampsia to a patient in layman's terms? Would you find the patients know about it and are concerned about it when they're coming to see you kind of in the first prenatal checks?
I think that's a brilliant question. So how I would normally broach it with patients is I would say preeclampsia is a condition which is specific to pregnancy. It's high blood pressure in pregnancy generally after 20 weeks of gestation, and it can be associated with other things, including problems with your kidneys, with your liver, with your brain potentially, and also it can make babies a bit small. In terms of awareness, I think many women are aware of preeclampsia, but they don't really know what it is. They know that it's something that happens in pregnancy, and then they might say, oh, my mum had that, or one of my friends or family members had it, but they're often really not kind of sure what it is or what it means. I have to say, I'm not sure that in the first antenatal appointment that they always talk about it. It's usually when they come back, or if they start to cotton on to the fact, oh, somebody's checking my blood pressure fairly regularly or dipping my urine, and they start to think about why that's being done.
Our next question is, in terms of research, is there more point focusing on the prediction or prevention of preeclampsia?
Good question again. So I think it depends on what area you're working in. So the area that I was working was mainly in risk prediction, and these screening algorithms are pretty popular, to be honest, in obstetric research. The prevention studies that have been done, as I say, that big roll neck trial with aspirin is sort of like the major one that has been done over the last couple of years. There's also some studies looking at use of statins to try and prevent preeclampsia. And I think it's called the STAMPS trial from the group in Birmingham, and also use of PPI, so like omeprazole or ranitidine, to also try and prevent preeclampsia. The major problem we have in obstetric research is that around safety of drugs. So they're very limited in what we can prescribe women. Women in general are reluctant, obviously, to take drugs in pregnancy, and a lot of the drugs that we use have been around without any evidence. We just know they're safe because we've used them for so long, and women are fairly content to take them, but we don't have much evidence for them. So things like cyclizine, for example, as an antiemetic, we don't have a lot of evidence-based use for that in pregnancy, but we know it's safe. We know it doesn't cause any teratogenicity in fetuses. So I suppose the trendy thing over the last sort of decade has been on sort of screening rather than prevention. But that big aspirin study that I showed you is probably the most groundbreaking thing that's been done recently.
Thank you for that. That was a really good answer. So moving on to our next question, some really good questions here. Thanks everyone for asking. Have you ever had resistance from pediatrics over delivery early?
Oh gosh, that's a difficult question to answer. I'd say yes, and often that's not because they don't accept why you want to deliver someone, but it's because of pressure of neonatal cots. So this is a problem we frequently run into. So
I suppose this one would be quite interesting and useful for medical students and MCQs. So what would be your management plan for a patient who has a strong likelihood of developing preeclampsia?
So is this sort of a booking then? If I saw someone a booking?
I assume so, yeah.
Okay, so I suppose it depends on the patient, but if I saw, for example, a woman who was 45, first pregnancy, was overweight, then I would say that she would be classed as high risk. So she's at risk of intrauterine growth restriction. So I would say regular growth scans in the third trimester from about 26 weeks gestation, usually every 3 weeks. She should have good midwifery care, so regular checks of her urine and blood pressure. You don't need to deviate too much from regular care, but I think it's just alerting her to the fact that she is at increased risk and sort of highlighting that to the midwives to refer in early. I would start her on aspirin. So essentially, if you have 2 moderate risk factors, then you should be started on aspirin or 1 major risk factor. So for example, a major risk factor would be if she had diabetes, type 1 diabetes as well, that would be a major risk factor. 2 moderate risk factors might be she's got a BMI over 30 and it's her first pregnancy. So she would be started on aspirin. And then you would assess other risks, such as risk of clots in pregnancy. So does she need Clexian to thin the blood in the third trimester, for example? But yeah, those would be the main things. And then I think counselling her about lifestyle as well. So if she's a smoker, I would try and advise her to stop smoking. So smoking is quite an interesting thing. So traditionally, when I was in medical school, you sort of were taught that smoking reduced your risk of preeclampsia. But the problem is it's not very good for the placenta. So it might help vasodilate maternal blood vessels, but then it has this kind of opposite effect in the placenta. So it'll cause it to mature more quickly. It'll make it small and it won't function as well. So usually try and get them to cut out the smoking as well.
Okay, I think we're going to finish off here because don't want to keep people too long on a Saturday evening.
Yeah.
So thank you so much, Kellyanne. That was truly wonderful. And feel free to stick around for Alice.
Thank you.
Thank you so much.
Oh, can I ask one question? Did anybody get the famous ankles?
I think there was a suggestion from Molly. Was it Kim K?
Yeah. Well done.
Yes, that was good. So thank you so much. We're gonna go on over to Alice now. If you could turn your video on.
It's telling me I can't turn it back on.
That's okay. Well, we can just, can you share your screen?
Oh, here we go. There we go.
Oh, hi, I can see you now. So, so this is Alice Clements from Action Preeclampsia, and she's going to be kindly sharing her experience of being diagnosed with preeclampsia and doing some very interesting research on men's health after their partners have been diagnosed with preeclampsia. So over to you, Alice.
Thank you. Okay. Yeah, so leading on from Kellyanne's speech then, I think when she was talking about the fact you have to listen to your patients is probably the most important thing that I would say to take away from it. So I actually had preeclampsia twice. In my first pregnancy, I don't think I was listened to. I don't think I was taken seriously. And it might not have had much of an effect if I was listened to a bit more, but there were some definite key things, key symptoms that were missed, which I'll sort of talk to you a little bit about now. And then in my second pregnancy, I was listened to and I was taken seriously, and it went so much smoother. So 2013, I was 23, so my age wasn't an issue. I was a full-time teacher. I was a healthy weight, so my BMI wasn't an issue. I was active. I did lots and lots of dancing. I was due the 22nd of March, 2014, and my partner was also not flagged up as being high BMI or the age wasn't an issue. So on paper, there was no reason why I would have been a high-risk patient. Family history, both white British, so again, no sort of major warning signs with our backgrounds. My only sort of, we don't really know what it was, but my great grandmother died 3 days after childbirth due to a blood clot. So all my gran knows about it was that it was a clot possibly on the brain. So that could have been something linked to preeclampsia. I don't know whether it just wasn't diagnosed very well back then. But my mum didn't have preeclampsia. My sister had 3 perfect pregnancies. So there was no warning signs from that either. Yeah, so again, on paper, nothing really flagged up. First trimester started really well, no sickness, it was quite an easy breeze. Up to the 12-week scan, everything was fine at the scan. No mention of watching out for any signs. I read all the pregnancy books, and I wasn't even aware that preeclampsia was a thing. Even in the pregnancy books, the one that I read, there was one tiny paragraph that said preeclampsia is an issue with some pregnancies. If you're worried about it, talk to your midwife. So I didn't think anything of it. Second trimester got a little bit more complicated. So I started to get sciatica. I ended up on crutches, pelvic girdle pain, sciatica. It was awful. Scans were still normal, and I was still having routine midwife appointments. And it was really in the 3rd trimester where it started to go quite wrong. So I always had horrific indigestion, just awful indigestion. Around week 30, my blood pressure was raised, and I had swollen feet and ankles. I've got a picture of it in a minute. It's unbelievable. I was measuring 2 weeks small, and then I was increased to the fortnightly midwife appointments because they started to feel I just needed extra monitoring. Preeclampsia was not mentioned at this point. I had no idea again about it. It wasn't mentioned. So these are my feet and my ankles at 30 weeks and 6 days. I went to my midwife with this and was told that some people do have increased swelling, and it was normal, and I just needed to raise my feet more because I was a teacher. I was on my feet a lot. Yeah, so I was told if I was ever sat down, I just needed to raise my feet. They didn't go down at all, really. They stayed like that almost consistently, and they were so uncomfortable. I kept going back, and I was kept told it's not an issue, it's fine. So then it was at 32 and 3 days where my blood pressure went sky high, and that was when the protein started to show. So I was sent to Gloucester Royal Hospital for the day assessment, put on labetalol, 2 tablets twice a day. That's probably the 200 milligrams, I think, that Kellyanne was talking about. Blood taken for liver function, which actually came back as fine, or I had no follow-up for it anyway. So I was discharged, booked for a growth scan. Now the pain in the ribs, I was asked, do I have pain under my right rib? And I said, oh yes, I had horrific indigestion. It's really, really awful. I was going through a bottle of Gaviscon a day, and it was not making it better. And so they asked if I had it, and I said yes, it's incredibly bad, but when I hit my side like this, it goes away. And their reaction was, oh well, that's fine then, it's just indigestion. So I had the swelling, I had the indigestion pain, I had high blood pressure, and I had the proteinuria showing. I was on labetalol, but I was sent home. This is me when was this? 32, and this is me on that day, actually. So this is me on the 32 and 3 days. Now, comparing my face here to in the picture, I hate this picture, but I think it's really, really important to look at and see just how extreme the swelling was for me. I actually couldn't breathe through my nose because it was so swollen so much. And yeah, it was awful. I mean, I don't look healthy, but I don't know whether they just thought I'd put on weight. But anyway, I hate that picture. So then trouble begins. So I was admitted to the maternity ward at this was just after this picture was taken. I was admitted to the maternity ward on 4-hour observations where they would come in and they would check my blood pressure. I was given the steroid injections. Again, preeclampsia was not mentioned at this point. I didn't have a conversation about what it could mean. I wasn't told I could have preterm birth. I was just given the steroid injections. I think I was told because it might start, there might be the possibility in the next couple of weeks that they need to look at early birth of the child, but preeclampsia wasn't mentioned. So I stayed in for a day, I think it was. I was discharged at 32 weeks and 4 days. I stayed home for the following day and just slept because I didn't sleep when I was in hospital. And I just literally remember losing the whole day to sleep. I was just exhausted. I couldn't stand up. I couldn't sit up for very long. I was so uncomfortable. And then the next day I went to work. So this was a Thursday. And I went back to work with the intention of working Thursday and Friday. I wasn't told that I had to stay on bed rest. I wasn't told that I shouldn't go to work. I was told to pretty much carry on as normal. Now I was on the labetalol and I'd had the steroids, and it was, we'll just see you again at the growth scan and see how things go. So I went to work on the Thursday. And I just felt horrific the whole day. I had a really foggy head. I wouldn't call it a headache. It was just really foggy and really heavy. I couldn't focus on anything. My conversations were going, like my sentences, everything was just all mixed. I couldn't really talk very well. Swelling wasn't moving, the indigestion wasn't moving. And it was really interesting what Kellyanne was saying about the eyes, because I actually walked down the corridor to my classroom, and I had all these children walking towards me, and I couldn't focus on a single face as they walked towards me. I remember thinking, I don't know who that child is, and I don't know if I even teach them. I cannot see. And I went into my classroom and I just cried, and I thought, this now is not right. I think I'm really poorly. And I remember just thinking, I think things are going to go bad. And they did. So that was the Thursday. I drove home from work, had an awful pain in my back. Even driving, I can remember just not getting comfy. I got home from work and I laid on the sofa and had a nap. And then because it was just too much pain, I had no energy to do anything, so I just laid on the sofa and had a nap. And it was my mum actually came up to check on me and said, things aren't right, we need to ring the maternity ward. So I think I've got my blood pressure numbers the wrong way around now. I know that it was those two numbers, I can't remember which way around they were. So yeah, so we went up to the maternity ward, and they commented about how agitated I was and how I couldn't sit still, and I was just so uncomfortable and I needed an answer straight away. And I'm not a rude person, but I was incredibly rude at this day, just so uncomfortable. And I can remember I must have only waited about 5 minutes, but I was just, it's too late, like you're keeping me waiting and I'm really poorly and I need an answer now. And I was so rude to them. And yeah, they said, you need to go to Gloucester. So I was like, oh, fine, like, come on, let's go. They said, no, the ambulance is on its way. I just remember thinking, well, this is ridiculous. Why is the ambulance on the way? I don't need an ambulance. I'm fine. Mum can take me to hospital. And yeah, I wheeled in a bed and they strapped me onto this bed, and I was just telling them how ridiculous it all was. And I was put in the back of the ambulance. And Mum wasn't allowed to come with me. I needed the head midwife came in the ambulance with me. And so I just waved goodbye to my mum. My husband was still at work. And my mum just made a comment that I looked green. It was the first time she looked at my face properly, and I looked green. So they gave me, I don't know how many tablets, I don't know what they were, but they gave me all these tablets in the ambulance, and I just vomited everywhere. I threw them all back up. And the pain in my ribs was unbelievable. By the time we got to Gloucester and by the time we got to intensive care, I just remember being curled up in a ball. I couldn't straighten my legs. I don't remember much. I remember I met Nina. So Nina was the midwife that took care of me straight away. And she was so influential throughout this whole thing, because she was the one that listened to me. She took this pain in my side really seriously. And I remember her saying to me that she'd never seen anybody come in that much pain, where I just couldn't uncurl myself. I was balled up, and yeah, I can't remember much. In fact, I can remember counting the ceiling tiles because I couldn't focus on anything else. I just was counting the ceiling tiles to take myself off to a different place, and they were asking me questions and I don't know if I was answering. But at this point, my husband made it up. I was put on magnesium sulfate, so I had 2 intense shots of it, and I was put on a drip. And it was awful. I wasn't warned about how it would feel, and it was horrific. So it went, I remember it going into my arm, and I remember it hitting, I could feel it going up and then hit my chest and all the way down, and I felt it go the whole way through my body. Like I was on fire, like they'd lit a match and it was just lighting me on fire. And I looked at my hands expecting them to literally be glowing red. I was so hot. I was sick again. Then I had some IV paracetamol, which is when the pain in my side eased. And then I started to loosen up a little bit, and I was talking a bit more then, and I can remember bits and pieces now. I was told that my liver and my kidneys were failing. They were starting to shut down, which was what the pain was. And I was told then that they would attempt to stabilize me overnight. So this is the Thursday night. They would attempt to stabilize me. If they couldn't stabilize me, I would be rushed in straight away for an emergency cesarean. And my husband had to get ready in the scrubs and everything. So I was told we'd be having the baby within the next 24 hours. So I went from being at work in the morning to thinking I had a couple of days to get things sorted. I had the growth scan the following week, and then we'd get some answers. Within 12 hours being told the baby's coming now or tomorrow. So I was prepped for emergency cesarean. Now they did stabilize me overnight. So I was taken in for the cesarean the following morning. So this was bang on 33 weeks. I've got a complete memory block now. I can't remember much from the cesarean. I can remember having to hold my hand up, and they just kept pumping in some sort of drugs. I think I had a bit of an abnormal bleed. So I remember things got a little bit stressed at the end of my cesarean, but I don't know much about it. I remember I had a crash team. I remember Isabel, my soon to be born daughter, had a crash team. So she was born weighing 3 pounds and 2 ounces. And they held her up and she was just so tiny, and she had scrawny little fingers, and she screamed. And then they took her over to the corner and worked on her, which I later found out was she needed to be resuscitated. And then she was put in a little incubator and wheeled past, and they stopped and they said, "Oh, look, there's your little girl, there she is." And I couldn't see her. I didn't know where she was. I could see the box, but I couldn't see her, and she was taken away. So I went up to recovery, and I just slept again. I don't remember much for the whole of the Friday. I remember waking up and being sick again. I can remember one particular midwife, I think I made her quite flustered because I was sort of going up and down the whole day. I was still on magnesium sulfate. And I remember this one midwife getting, like, just running around, running from me to somebody else to a doctor and then running back again. But I don't remember much. And my poor husband was just stuck in the middle. He later talks about this time as having to make the decision of sitting next to me and saying goodbye to me, or sitting next to our daughter and saying goodbye to our daughter. That's how he saw that time. He had to decide who he was going to be sat next to. So, yeah. There we go. So that's Isabel in the neonatal unit. That is my first cuddle, which was actually at, she's 26 hours old there. I didn't see her for the first 26 hours. So I had to be wheeled down there to see her. Yeah, she's teeny tiny. So Belle stayed on oxygen for 2 hours. So I didn't ever see her with the mask on. She was moved from the intensive care ward to one of the nurseries within neonatal unit at 4 days old. She stayed in the unit for 4 weeks. And I expressed and I breastfed to get her home. And she was 4 pounds 8 ounces coming home. Now, me personally, I really struggled for easily the first year, if not more, if I'm honest about it. I was entitled to 6 free counselling sessions through Bliss, which I don't think they do anymore. But that was amazing, just to sort of get me through that first barrier. And then I went back into counselling in August 2016 for a year. So what I've done since then is I've actually just completed a master's in psychology, where I looked at the mental health of people after preeclampsia, of men specifically. So there's a lot of research that shows women who go through preeclampsia are more likely to have postnatal depression and post-traumatic stress because of the increased risk of preterm birth, increased risk of cesarean section, and increased risk of very small weight babies who need neonatal unit help. So it's quite well known now, it's quite well researched that women are likely to get postnatal depression and post-traumatic stress after experiencing preeclampsia. But my research was actually looking at the men's mental health as well. And I found that men are actually also at an increased risk of postnatal depression and post-traumatic stress, which is a very, very under-researched topic. Men's mental health following childbirth is not really something that is focused on at the moment. But yeah, it's my research. I did find an increased risk. So I'm actually looking at now doing a PhD in men's mental health. Unfortunately, not focusing on preeclampsia. I'm going to be hopefully focusing on bipolar depression. But I would definitely want to come back to men's mental health with preeclampsia at some point in the future. I think it's fascinating. So 2017, we decided to have another one. We decided to go through it. I felt there was a lot that I'd missed out on with my first pregnancy and my first birth. I didn't get to enjoy any of it. I didn't get the 3rd trimester. I didn't get that first cuddle after you deliver. I missed out on the first day of Belle being born. I missed out on the first month because she was in hospital, and it was just constantly going backwards and forwards to the hospital. So through the counselling, I decided, actually, I did want to try it again. I want to know, can I go through a pregnancy and enjoy it? My sister enjoyed it, so why can't I? And we gave it another go. So this time I was on extra monitoring from the beginning. I was consultant led. So that was actually the same consultant I had for my first child. I had appointments every month, which then increased to every 2 weeks and then increased to weekly. So that was just brilliant. I had loads of growth scans. I've got so many scan pictures of my second one. It was brilliant. But I always had the constant worry. I always felt I was increasing my an increased risk of getting preeclampsia again, an increased risk of high blood pressure. I always felt quite stressed out. And I had the pelvic girdle pain again, but I was on aspirin for this pregnancy. So I did have the aspirin for this one. But I went to the day assessment centre 3 times, and if I had a chance, I asked them to do a blood test. It's just blood tests every week. Like, yes, I want to know what's going on. So then we had Arthur, who was born the 22nd of December, so only 9 days early. Now, he was born early because I asked him to be born early. It was an elective cesarean, and I pushed for it to be before Christmas. So my due date wasn't until the end of December. And my consultant did say that she was happy for me to wait until after Christmas. And I said I wasn't. I had the high blood pressure. It was all sort of going up in the same way. And I just said, I want him here. I don't want to go through the emergency that I went through before. I want an elective. So we booked it in early. He was a healthy weight, £7.15, and when he was born, I just remember looking at him and thinking, like, he's so chubby, because Isabel was so tiny and Arthur was so chubby. And I had the cuddle. I got him straight away, breastfed straight away, went up to recovery, and yeah, it was in the recovery ward, having a great time, eating my toast, having a cup of tea. And then my blood pressure started to increase again, had blood test taken, and I actually had postpartum preeclampsia this time. So again, I was put on labetalol, a lower dose this time, but I was put on labetalol, I was monitored, and yeah, my blood pressure was still playing a few funny games, but we were discharged in time for Christmas, which was lovely. And there's Arthur, little chubby one, and that's Isabel with Arthur the first time that she met him as well. So now they are 2 cheeky little children. Isabel was discharged from any sort of hospital care in terms of her development when she was 2 years old. We did find out this year that she's got quite bad eyesight in her one eye, so she does now wear glasses, which could be linked to the fact that she was preterm birth. We're not sure, but yeah, she's absolutely fine. There's no implications in her development and her awareness because she was preterm. And Arthur is just an absolute little troublemaker. But yeah, they're both happy, they're both healthy. And I was told by one particular doctor that if I ever feel the need to have a 3rd baby, I should just get a cat instead, because of the increased risk of having preeclampsia again. I'm pretty much guaranteed to get it. And I've had my questions answered. I can't enjoy pregnancy. I will get preeclampsia, so I'm not experiencing it again. But yeah.
Thanks so much, Alice. I'm sure I speak for everybody here, to say that we're just so thankful, and it just means so much for us as medical students and future doctors and current doctors to hear in so much detail about, what our patients go through, and to really understand. So thanks again. There's been a few messages in the chat and in the Slido about people saying thank you. So are you okay to have a few questions?
Yeah, definitely.
What Ruchika asks, what were the changes in your interaction with medical staff between your first and your second pregnancy, and did you feel more heard?
Yeah, so the first, I was just on a normal sort of schedule. I only had the midwife, and I just saw her on the normal, the routine checkups. So I think as it passed 20 weeks, you don't have very much interaction with the midwives. And it was just at my routine checkups where the high blood pressure was found. I didn't actually get the growth scan with my first one because I ended up delivering her before. But then with my second, I had consultancy meetings right from the word go. I had 5 or 6 growth scans. So it was every 4 weeks I had a growth scan, and I ended up having either a midwife appointment or a consultancy appointment every week in the lab from 30 weeks. So I felt so much more taken care of. And, even when I was at the end, although my blood pressure wasn't necessarily out of control, I was worried, and I felt that preeclampsia was looming again, and I felt the doom. And they listened and they took me seriously, and that was why we ended up having Arthur before the Christmas break rather than after. So yeah, I've definitely taken more seriously the second time around.
Mm-hmm. And I suppose just I would like to know is what could the kind of healthcare professionals you met the first time around, what would you say that they could have done better?
I think there were a few missed signs. So I think that awful picture of me where I'm just so swollen and so bloated, if they'd have listened, that's not me, that's not how I normally am, that's not how I normally look. And I think the swelling was so bad, along with the high blood pressure and everything. There were all the signs there. And yeah, I do feel that it was sort of, the ball was dropped a little bit with me to begin with, especially when they asked if I had the pain, and I said yes, it's awful, but because I could hit it and it would go away, they dismissed it. So yeah, maybe if I'd have known more about preeclampsia, I would have pushed a little bit harder, but it was my first pregnancy, I didn't know. So yeah, I think a few things were missed.
I'm sure we'll take that away and think about this in the future. Our next question, I think, is referring to, you mentioned counseling. So did you find the counseling sessions were helpful after your first pregnancy?
Yes, so I had the 6 free sessions, which were it wasn't, because we only had 6, we only focused on a very, very short time frame. But that definitely opened up my mental barriers, because I just blocked out the whole thing. I didn't want to discuss anything. I couldn't remember anything. I didn't want to remember any of it. But the first 6 sessions, I got through that. I could then talk about it, because my mental health was in such a bad place that if anybody would ask how Isabel was, I could answer fine. If anybody asked how I was, I would burst into tears. Like, I don't want to talk about me. I don't want you to be interested in me. My only focus is Isabel, and if she's okay. So the first 6 sessions definitely got me through that. And it was then the private counselling that I went through where we discovered it was more sort of post-traumatic stress and dealing with that. So I still get flashbacks now. January is a particularly bad month for me. I know that my emotions are going to go up and down the whole of January. And is from the 14th of January. That was when I started to swell. My feet started to swell. And I know every January, from pretty much the 14th of January, I'm going to have a bad 2 weeks until Belle's birthday. And even now, I find it difficult to celebrate her birthday. It's still, I've only had 1 year where I haven't cried, either on her birthday or the day before her birthday. And that was the year that Arthur was newborn, because I was sleep deprived. But yeah, the counselling definitely helped me to get through it and helped with my coping strategies, and just made me aware that I wasn't going crazy, that postnatal depression and post-traumatic stress is ongoing and really bad in some cases.
And the next question kind of ties into your previous question as well. And Katie asks, do you think that group therapy would be useful? I assume it's with other preeclampsia patients, or maybe it's with family. I'm not sure what she means, but
that's a really interesting point. Part of why my mental health was so bad afterwards was that I met other people who had preeclampsia, but none of them had had it as bad as me. None of them had the liver and the kidney failure. None of them had to have magnesium sulfate. None of them had to have an emergency cesarean. So I was talking to people about their preeclampsia experiences, and they were all like, no, we just had to have labetalol, and then we were like, we had a growth scan every now and again, and we were a couple of weeks early. Whereas so then I stopped talking about it, because I was like, right, okay, I don't understand why my experience was so bad. Maybe I've exaggerated some of it. And then I found one person who had a similar experience to me, and she actually ended up having a fit. So she went from preeclampsia to eclampsia. And that was then when I learned that preeclampsia and severe preeclampsia are very different things. And preeclampsia can be monitored. Severe preeclampsia and eclampsia is then when it starts getting more severe, and there's not much you can do with it other than to deliver the baby. So once I understood that, then yes, that really helped. But I think if it was group therapy with people who had the mild preeclampsia, I think that would have actually put me off talking about it. My husband has actually had therapy as well, so he's gone into counselling, and I think he was in for about 6 months private counselling for his mental health as well, which then is what led me on to my master's research.
And this actually leads on nicely to our next question. Maybe we'll do one or two more, which is about, men's health and preeclampsia. So what inspired you to look into men's health? And I suppose, what did you find in your search?
So I found that, well, the reason that I started doing it was because nobody asked how Carl was doing. Nobody asked if he was okay. And he very much went into a fight or flight mode. Like I was saying, he had to make the decision. Who does he sit next to? I was told I wasn't going to make it through the night before I had the C-section. So he had to sit there and watch everything unfold. I can't remember a lot of it. He witnessed everything, and then had to make the decision of, Isabel's tiny, she's on oxygen, she might not make it. She's already had to be resuscitated. And I'm in recovery, just not anywhere, just whacked out. And does he sit next to me, or does he sit next to Belle? And he had to leave us. In this current climate, I don't know how men are experiencing things. They can't even be involved at all. He had to leave to go home and sleep. I was in the same building as Belle. I couldn't be next to her, but I was in the same building. I knew she was only downstairs. We live 45 minutes away from the hospital, and he was traveling up and down every day. And I really noticed, when I got better, or when I was seeking help for my mental health, he then actually started to decline, and his mental health went very, very down a very similar route to mine. And I noticed he had some sort of post-traumatic stress as well. And that was then when he went into counselling. But through my research, I found that actually the men, if their partner experiences severe preeclampsia, where it is the rush, it's the emergency cesarean, it's the preterm birth, the neonatal unit stay, all of those things combined do put them at a much higher risk of developing postnatal depression and post-traumatic stress than the pre-eclampsia, right? So it's the severe pre-eclampsia rather than the mild pre-eclampsia that can be monitored.
Okay, I think we'll leave it there. So I suppose perhaps, so that we finish on a nice and positive note, is there anything you'd like to say to us as future medical student, as future doctors, excuse me, and I'm sure other healthcare professionals as well, maybe, you know, when we see somebody who might be developing preeclampsia or even is worried about preeclampsia, what would you say to us that, you know, that we keep in mind?
I think exactly what Kellyanne was saying, that actually stay on top of the research, know what the signs are, go to more events like this, keep up to date with it, and listen to what your patients are saying, get to know them as much as you can, as much as you have time to get to know them. And yeah, even if they are young, even if it is their first pregnancy, there's a lot